Good morning, seniors and my friends. I've been given a topic of bifurcation, and in the last 2 days, you have seen that out of the 4 cases which have been shown, 2 of the cases were dealt in a different fashion because they were the bifurcation. Of course, Srinivas did a beautiful dedicated bifurcation stenting, and today we have seen Padmanabhan doing a Zabo technique. So let's say the fact that we all face in day-to-day practice dealing with the bifurcation lesion is a challenge. It tests our abilities, and that's a task I have to deal today. It reminds me something like it's like something like a Telangana issue. Okay, still not settled whether it's a one state or 2 states or one stent or 2 stents. The limitations and the fixed concepts we have probably are also responsible for the dealing with the bifurcation lesions. What are the limitations? The bifurcation lesions which are randomized are most of the times are suitable for the provisional stenting. So that's the reason we go with the provisional stentings. And bifurcation lesions which need to be treated with 2 stents are usually not randomized. So that is the reason you have seen that there are very few randomized trials in the bifurcation stentings. I'll go through those trials a little later, but you can see that there are very, very few data as far as the randomized trials are concerned. Lesions which are suitable for 1 or 2 stents, this is our concept. Basically, we go with this fixed mind. That lesions which are suitable for 1 or 2 stents, routine implantation of 2 stents does not give any advantage compared to the routine implantation of 1 stent and cross over to the second stent when needed. If you decide to implant 2 stents, you take more responsibilities. An optimal result will give a low MACE rate even if you follow them with an angiogram. And whereas the suboptimal result may increase the risk of thrombosis of the side branch and sometimes of the main branch. And if you are deciding to implant only 1 stent, you are mainly responsible about the side branch. That is an incorrect decision may lead to the side branch closure. So what is basically is the final decision is a balance between the clinical relevance of the side branch, that is the risk of occlusion, and how confident is the operator to obtain an optimal result. What are the problems with bifurcation lesions we normally face? What normally when you go, these are the things which we come across often. Should I wire the side branch? Yes, very little to lose because except for a guide wire, you don't lose anything by wiring the side branch. Should I implant 1 or 2 stents? Probably this is the answer which we need. At the end of the talk, probably I should be able to make it more give more clarification on that. Should I perform a kissing inflation? In general, only if you have it implanted 2 stents, the kissing is mandatory. In other circumstances, if the side branch is important and shows an unsatisfactory result, probably you need to do a kissing in the time. Kissing is not always important in provisional stenting. What is KIO? Keep it open hypothesis. This I would like to mention it a little detail in subsequent slides. When you are only concerned about the side branch occlusion, regardless of the residual stenosis, is keep it open. The strategy means to place a guide wire in the side branch with the goal to finish the procedure with either TIMI 1, TIMI 2 or TIMI 3 flows in the side branch without any concern for the residual stenosis. I'll revisit this keep it open again. When should I plan for a KIO? For any side branch which is large enough to be worried about the closure and without much concern about the residual stenosis and the extent of ischemia, in those things, probably we should adapt a open strategy. 1 or 2 stents have an intention to treat. Why not implant 1 stent all the times and you can always implant the second one? The procedure to implant a second stent may not be all the time easy, which performed in a case of need compared to the elective performance. And this is more important, is the selection of the best technique should be taken beforehand rather than as a bailout procedure. If you try to push the second stent as a bailout procedure, obviously you will end up in the complication. So I think before we really decide whether you want to go with a provisional or you want to go with a 2 stent strategy, the decision should be taken before the procedure is started. Why not implant 2 stents all the times? Implanting 2 stents as an intention to treat is more complex. 2 stents is more expensive. And there is no demonstration that implanting 2 stents all the time is superior to the provisional strategy. There is a perception that implanting 2 stents may be associated with a high risk of stent thrombosis. This is now again, as I said at the beginning, that basically there are certain concepts which we carry with us. We generally believe that if you put 2 stents, probably stent thrombosis rates are higher. However, the data does not support this. So what exactly we are, as I said, that bifurcations are more often we come across than what we really believe. Although the percentage wise 15 to 20%, but majority of times you see that in day-to-day practice you come across the bifurcation lesions problem more often. Why in individualized approach? Variations in anatomy. Left main bifurcation disease, you need to have a separate strategy. Plaque burden and location of the plaque. Angle between the main branch and the side branch. And dynamic changes during the treatment. That is a plaque shift or the dissection. And no two bifurcations are always identical. So what is the proposed strategy for the bifurcations? My proposed strategy is keep it open strategy, provisional are the two-strand strategy. Why wire both the branches? Because it protects the side branch. The jailed side branch wires facilitates the widening of the angle between the main branch and the side branch by acting as a marker for the side branch ostium. If the side branch is occluded, that's how you can actually push the recrossing you can do, and the changing the angle of the side branch takeoff. In the tulip multi-center study, because I have seen few of the operators, they don't bother to wire the side branch. And in one of the multi-center studies, it has been shown that if you don't wire the side branch, the re-occlusion rates are high, and there is between 2% to 15% during the follow-up re-intervention was required when the side branch is closed. And of course, as we know that the hydrophilic wires should not be used for the jailing the side branch. Why protect the side branch from closure? Because occlusion of the side branch of more than 1 millimeter is associated with 14% incidences on myocardial infarctions. Side branch closure associated with a large peri-procedural MIs. So coming back to what is keep it open strategy? When the side branch has an ostial or diffuse disease, and when the side branch is not suitable, too small for the stenting, or clinically not relevant. What do? We take a 6-branch guiding catheter, wire both the branches, dilate main branch if needed, stent main branch and leave wire in the side branch, post dilatation of the main branch with jailed wire in the side branch. So the point is, do not rewire side branch or post dilate or pre-dilate the side branch. So important point is, even though you have a lesion in the side branch, don't pre-dilate the lesion. But generally our tendency is that when you are adapting a keep it open strategy, that means you're not handling the side branch at all. Whether it has got a lesion or not, you're only worried that it should not get close. That's the reason you just jail the wire, do the procedure and then come out. And what do we do in the provisional strategies? The side branch has a minimal disease or only at the ostium. When the side branch is too suitable for the stenting, we go ahead with the 6-French guiding, unless, of course, there are like Zions Promus and other things, probably they require a 7-French guiding. Wire both the branches, dilate main branch and side branch if needed, stent main branch leaving a wire in the side branch, rewire side branch and then remove the jailed wire. That's how you do the crossing, and do a kissing balloon inflation all the time when you're doing a provisional, and when the vessel size is more than 2 millimeters, 2 to 2.75 millimeters. Stent side branch only if suboptimal results. The side branch, in the first thing is rewire the side branch and perform high pressure side branch dilatation followed by simultaneous dilatation. Because this is what it shows is that when you do only a simultaneous balloon dilatation of both the branches without performing high pressure dilatation of the side branch, the center one is the one which shows with a 1-step case, whereas you do a 2-step case, the stent, expansion is better with that. Of course, this is an algorithm, and I don't want to go into the different techniques. I know all of you are aware of it, but the tap technique, which I thought it's worth mentioning, because we have in our center, we have adapted this as our strategy, a default strategy in most of the bifurcation stenting. Mostly for the left main bifurcations, we do the tap stenting, and even in the international conferences, we have seen that most of the time tap stenting is taken as a default strategy. What exactly is a tap stenting is? The T stenting with a protrusion technique. Here you wire both the branches and pre-dilate the main and the side branch as required. Stent the main branch, jailing the side branch wire. Once the stent is deployed in the main branch, the side branch is recrossed and to the main branch stent struts. After that, position stent in the side branch, ensuring the coverage of ostium with minimal protrusion into the main branch, and place non-compliant balloon in the main branch stent. So what you do is, it's something like a mini crush. You pull back a little bit of a strut is left into the main branch, and what you do next after this is that inflate the delivery balloon in the side branch with the main balloon and the main balloon simultaneously. So what we do is, after crossing the side branch, take the main balloon into the main stent, make it as a marker, and generally what you do is, either in the LAO caudal position or in AP caudal position, take the 2 markers of the balloon as the markers, and then position the other stent in the center of it, which gives you the exact positioning, and probably 1 or 2 stents are inside the main branch, and inflate both the balloons, the main branch balloon as well as the side branch balloon. So basically, the stent is not crushed there, and as well as the ostium is not missed. So that's the way we do a tap stenting. I don't want to go into that, all these, the different types of the stenting procedures. Obviously is done where the wide angle is there, when the angle of the main branch and the side branch is more than 90 degrees, you normally use the T stenting. And of course, the crush stenting is again for when the angle is narrower, you do a crush stenting. Nowadays it is a mini crush which is being in use, and these are the different steps of the thing. And culotte is, of course, where what we do in culotte is that main branch to a small, the side angle branch which is having a smaller, that's how you place the stent, and after that you place the stent into the main branch. So basically you place the main stent from the main branch into a narrower branch, a smaller branch, the first stent, followed by the main branch stenting into the main vessel. And culotte is again when you really see the data between the culotte and crush, the culotte has shown a better results compared to the crush technique. Reverse crush is again is usually a provisional thing. When you fail to do a stenting, then normally you take a reverse crush stenting. V stenting is the one where you normally do a 0-1-1 method, where the proximal part of the main branch is not having any disease. In those situations, you can go with the V stenting. And of course, the second is the SKS stenting, is a double barrel stenting. It is basically very easy to perform when you have a 1-1-1, but the problem with this is the recrossing. If the stent blockade is there, then it is really difficult to recross with the double barrels. And usually SKS is avoided if you have a chances of, if you are suspecting any re-occlusion. So in those situations, SKS should be avoided. Otherwise, to perform it's a pretty simple technique. You know, coming to the different techniques, whatever I have shown, what exactly is the data which shows about the meta-analysis of all these randomized trials? What is the result and where do we stand? So these are the few trials which have been shown that which have been done for the randomized trials done in the bifurcation lesions. And if you see the meta-analysis of all these trials, you see the mortality more or less remains the same whether you have a 1-stent strategy or 2-stent strategy. The myocardial infarction, probably the only difference, the single stent versus a double stent strategy is where the myocardial infarction. It is not the stent thrombosis which basically affects it. It is the myocardial infarction. You can see the comparison between the provisional is 3.6 compared to the 2 stents. It is 6.8, which is statistically significant. So the only thing is when you use a 2-stent strategy, probably you are increasing the myocardial infarctions in those patients. And whereas it coming to the TLR remains more or less the same in both the strategies. And similarly, the main branch stenosis remains the same. It's a little in favor of the 2-stent, but otherwise it is the same. And side branch stenosis also remains the same. And stent thrombosis, what we believe that probably stent thrombosis is more with the 2-stent strategy, but however the meta-analysis did not show that, and it shows that more or less it is the same in both the strategies. So of course these are the different trials where there was a crossover between the 1-stent to the 2nd stent. And as Dr. Shailendra Singh has put it rightly, that it is basically the FFR probably is the guiding force when you really have a side branch occlusion. And if you do the FFR, and you can see the scatter here, that the percentage stenosis, if it is more than 75 or 80%, and there it is the maximum scatter of the relevant, which is functionally significant, and probably those are the branches which requires the re-intervention in those side branches where it is occluded more than 80%. But for oculostenotic reflex, normally what we land up in most of the bifurcation lesions is, we see the side branch, it is occluded about 70% or 50%, and then we tend to recross and do a dilatation and probably do the kissing dilatation, and again we land up in a. So in real life, final kissing balloon inflation is performed 30 to 50% of the times with provisional stenting, and we do not know what should happen if the operators did not perform the final kissing balloon at all. The bottom line could be that final kissing balloon is not mandatory, but there are situations where it is important. As I said yesterday, that the same thing is, of course, there is a Nordic 3 study which has come with a kiss versus no kiss, because what we generally believe is that this is a study which showed that at the end of the 6 months, the MACE rates, the myocardial infarctions, TLR, and the ischemia more or less remain the same between the kiss or no kiss. So we are not very sure whether even in the provisional stenting we should essentially do a kiss for all these patients. So what are the conclusions is, you should take the responsibility for a poor result. With two stents, a poor result may affect the main branch and the side branch. With one stent, it may affect only the side branch. So what you need to consider is angle of the both branches, their size and the territory of distribution, and most important is how confident is the operator with a specific approach.